So, hi everybody. First of all, I have to introduce shortly myself. So, I'm Professor Sébastien Soize, coming from Reims, a city in France when you probably know with the champagne, and you can see the name of this city on every bottle. Otherwise, for now, you also know me. um, so, I will talk today about something quite new. Flat panel detector, or CBCT, and perfusion imaging. I will just try to explain to you the journey we have actually with Circle to go to try to develop that. So we're just at the beginning of the journey. The first thing is that I have to explain to you is my motivations, the clinical motivations as an interventional neuroradiologist to do so. So the first slide I want to show you is that one. It's a little bit provocative. I just learned one thing from the way the President of the United States talked to the people is that the most you shock them and you give fake news, the more the people listen to you. So I try to shock you a little bit. Like, for me, the thing is, we already do, as you said, perfusion imaging for years and years to select the patients for thrombolytics or thrombectomy. Actually, for me, this is from the pre-endovascular era, what we are doing, or workflow. Meaning, we have done almost nothing since thrombectomy, 10 years. Plenty of people try to improve their workflow to manage to make the patients going faster and faster to the thrombectomy suite. But finally, the thing was just to concentrate about stabilizing the patients, going fast on extra-hospital care, also trying to improve in-hospital delays. But finally, the only forgotten part is here, in between. Here you got the workflows from the French study TRACE, which was one of the studies that was about validating mechanical thrombectomy. I really like this study from a colleague because you can see that there's almost no delay when you perform well MRI or CT. Honestly, to know very well these patients, CT, you got CT perfusion, and MRI, you almost never have perfusion. This is probably why there's almost no difference. The thing is, these two delays, I just keep randomization delay, are the delay we can try to compress, 30 to 50 minutes. Not because of the acquisition of a scanner, it's very, very fast, but finally, just because we have to transfer many times the patients, stroke patients, they are not compliant, can be difficult. Sometimes they vomit in the scanner or everything like that, so you lose a lot of time. And as you see, 30 to 60 minutes, it's a lot of neuron dying, but you already know it. So based on that, some endovascular news journals said like, okay, ConBeam can be very interesting in shortening delays. At that time, it was just talking about doing a ConBeam just to rule out hemorrhage. That's all. Then people try to work to direct to angio workflows. Plenty of people now worked on that. And as a result, you can see that it's very time-saving. It's very, very cost-effective. And then also you can unburden your emergencies department if you do so, if you go through the emergencies department. And you got also better functional outcomes. Look at this meta-analysis. That's just the two data in yellow which are important. You save around 30 minutes by doing so. And you got 25% better results on functional outcome. In this meta-analysis, You just got one randomized studies. The other ones are not. But anyway, there's still quite good evidence. We also got a study named Direct Angio in France. And this one, unfortunately, is not published, but will be soon, and it's negative. But only because we just got bad luck, because there was too much hemorrhage in the arm direct angio. Too much primary hemorrhage. So, bad luck. So, trying to shock you again. Is it the end of CTP and MR perfusion? Will you be here today? Ah. Okay, of course, no. And just to reassure you, perfusion is doing a lot of things, very, very interesting and good things now. If you can look at these studies, so there's one with the Circare software. The other ones, they are focusing on extending thrombolysis or thrombectomy using perfusion imaging. So finally, without perfusion imaging, actually we will just do thrombectomy within 0 to 6 hours, and then finished. So now that you are almost convinced that this can be interesting to save a little bit more of extra neurons, we'll talk about how we can do it, how it can be useful. Maybe I can just, Cindy, with your talk, I can add another line now I'm thinking about. So we can, of course, select good candidates for thrombectomy. We can also have a second look to the patients that are coming from far, far centers, because there may be some changes and you can just assess the changes before treating the patients. You can also select candidates for thrombectomy, for therapies after thrombectomy, meaning actually we are doing a study in the department where we just assess whether we randomize whether even with a good reperfusion we can put tenecteplase or not in the patients just to unlock the microperfusion, microcirculation. So probably doing perfusion before can really help select the good patients. We can also try to estimate the risk of hemorrhagic transformation with the early hyperperfusion. And maybe also having a whole brain coverage when you treat mechanically vasospasm can be interesting to have a look at the perfusion before and after what you've done. I will add this on the next time. So finally, where are we? We are here. Still a lot of way to do. There's big challenges here. The first big challenge is that we just got a poor acquisition of data, honestly. Compared to a CT scan where you can obtain data from 0.25 seconds per time frame, here you got only 4 to 8 seconds per time frame, meaning you got dramatically decreased your temporal resolution. You got a lot of beam hardening artifacts, motion correction artifacts where we can fix this a little bit. You got also sometimes some issues with the reconstruction of the images. And then, and which you will see on the other slides is also important for me, we have to avoid really time-consuming post-processing. This is where Circare can help also a lot. So actually, what I found in the literature is only few studies. I noticed 5 of importance. We got also 2 that I will not show you, which are from China, just about carotid stenosis, 10 patients each. And the data is just, they just show that it doesn't work. So let's skip that one. There's plenty of heterogeneity just in evaluating the perfusion, how they do it, how they reconstruct it. Also, one of the biggest issues is the delay between the examination, meaning when you try to compare CT perfusion or MR perfusion to CBCT perfusion, sometimes the patient is not so good and you have to wait 1 or 2 hours in between. So you compare pears with apples, finally. And for me, the biggest and most interesting part, actually no one's evaluated the impact on the clinical decision, meaning if you got a 10 milliliter difference in the salvageable tissue, is it worth or not? Honestly, as an interventional radiologist, I don't care. As far as I take the same decision, everything's fine. So the first, or one of the first study, but the first to me that is of importance is 12 years ago. And as you see, this is a model of basilar artery occlusion. And the first map that were acquired. The thing you have to know is that this is not human. What you see is CBCT from dogs. Sorry, Cindy, with the photo of your dog. Then the second one, 10 years ago. 10 years ago, they tried to image 12 patients and to compare to MR perfusion. You got here the maps. Also, the technique used has not changed from this point to now, or a little bit, just a little bit improved, but it's always the same thing, using Siemens angiosuite, using 10 acquisitions, whole brain acquisitions, in a time frame of 50 to 60 seconds. A lot of contrast injected. And then you can extract from the phases, from the arterial phases, to see the occlusion, and also the maps. The maps looks like this. So you see it's a bit like you're doing arterial spin labeling maps. It's a little bit ugly. Anyway, we don't care if it's ugly or not. We just want to make a clinical decision. Second study of interest, 3 years ago, and here they just tried, it's always with Siemens, here they try with Syngovia, and they try 3 methods, just putting region of interest or volumes, trying to see what's the best to detect hypoperfusion. And finally, what they found is just that the volume is better than doing small runs. Okay, interesting, but quite predictable. And another thing is that finally you got quite a moderate correlation when you try to evaluate the basic parameters. It's really basic parameters like MTT, Tmax, CBF, and the correlation was quite not enough good. Probably the most advanced actually paper, sorry to have put this name into so big. So 20 patients, 6 centers to have 20 patients, anterior circulation occlusions with Siemens and Rapid software, and they compared CTP to CBCT perfusion imaging. The thing is, they do a preliminary study in 2021, and then another study. The preliminary study, they just show that the CBF threshold that is commonly used as less than 30% was not the best, and probably with CBCT we can use a smaller threshold of 45% to get more sensitive to the penumbra. And the other study, which is that one, showed that the correlation was quite good just to see the CBF volumes, but finally quite poor when you try to have the true mismatch. So actually a little bit disappointing, because it's not enough probably to take clinical decision when you got just a R2, R square of 0.3. It's not enough. The last one from Switzerland, again with Siemens machine and a Siemens prototype to reconstruct the data, manual segmentation. So here also one point I told you, very time consuming if you have to do it manually, no clinical impact probably. And the correlation was quite low and the agreement was weak to see the core and the hypoperfusion areas. As you can see here up, and down. You got flat panel detector on your left and the true one on the right. It's a little bit, the images are a little bit different. Probably this one, they will get much more close decision making than the previous one. Now I have to show you what we've done with CRCare, what we will do also, the mountain. So first of all, thanks for the people from CRCare just to agree me to present their work, because for that part, this is only their work, not mine. They worked on a Siemens machine, and they have done exactly the same as the study I showed you. 10 phase acquisition, 6 seconds in between, and same exactly reconstruction. What they got is that, and quite a precise evaluation of the mismatch. This is with 10 phases. What they try to do is just to take half of the phases, so just only five acquisitions, and to see whether it can just be a good surrogate for to evaluate the mismatch volume. And here it's quite good with that one, taking 2, 4, 6, 8, and 10 phases. If you got a little bit of shift, then you see we are not on the same times, 1, 3, 5, 7, 9 phases. And now there's a little bit of more inaccuracy into the data, and probably a different clinical decision making. So actually, what are the lessons from this? That it's probably highly probable that we can just use 5 or 6 dynamic acquisitions to have a good perfusion imaging on CBCT. But the thing is, the timing of bolus injection, the timing also you start the imaging acquisition is very, very important. We got plenty of works to do, like trying different protocols to optimize injection. As I told you, as Serkay said, it's really important, and it's true. The other thing is try to determine the optimal number of phases, because maybe it's not 5, but it may be 6 or 7. Honestly, it depends, it changes a lot the dose. So if we can stay on 5, I will be really, very, very happy. Trying to optimize X-per-CT parameters, which is the CBCT from Philips we use, and wait for the butterfly acquisition we will have in 2 months, so that we can probably decrease a lot the artifacts. I will show you like 2 studies on Philips and Angiosuite, because now you have, what you have to understand is we are shifting from all the works done with Siemens to a Philips and Angiosuite with all the problems that can come with. Okay. So here you have some scans that you can improve just by moving a little bit your parameters. So we haven't done this so far, and we can probably improve our data doing that. The other one is that with the butterfly acquisition, we can really reduce a lot of artifacts. The first artifact we want to reduce, of course, is beam hardening artifacts. And we are waiting for that because it can really help. So translating from Siemens to Philips, our actual protocol is to have 6 acquisition, 1 without contrast as a mask, 5 with after contrast injection. This is the same protocol injection as Siemens use, all the studies. One interesting thing is in each study, the contrast agent is different, and the osmolarity of the contrast agent is also different. So we don't know if it's something big or not. We have to test. And what's really interesting in our protocol is that the Philips acquisition is in 5 seconds, and it's a super low dose acquisition, meaning the dose is half of the acquisition of previous Siemens work. With that, it's not just half because of 6 phases versus 10. It's just half by phase, meaning if we just do 6 of a half, it means a quarter of the dose. And the difference also is that the Philips angio suite do not acquire as much movements as the Siemens one, meaning you can just do a 200 degrees acquisition, then you have to go back, and then you can restart the new acquisition. With Siemens, you can do an acquisition on one side and on the other side directly, which is easier. I'm showing you a patient that we did recently, an 85 years old woman. At that time, she was at 4 hours from symptoms onset. She was at 2 hours drive from her hospital. So there's still an occlusion of the left M1, already a small infarct core, a clot around 2 centimeters. And this is what we acquired when the patients arrived in the angio suite. So here you have an MTT map, CBF or Tmax map you can change, and the evaluation of the sad vegetable tissue. The thing is here, we took a threshold at 30%, not 45%, so we don't know what we will have. We just have to change and see whether it can improve the determination of the mismatch volume. So of note, during the 2 hours, she clearly worsened. NIHSS 18 now. Here you got the angio with still the occlusion, still some collaterals at least. We just did, the clot is here, one aspiration in front of the clot. And the patient was quite fast recanalized. So the time between the CBCT acquisition and the reperfusion is 18 minutes. And the patient improved a little bit at the beginning and then dramatically improved. The thing is, with patients more than 80 years old, you can have delayed improvement due to a kind of brain saturation effect of the flow that is coming. They cannot adapt as young people. So sometimes we have to wait to see the true effect of the thrombectomy, which is the case here. So finally, with such cases, this is really encouraging, and we believe we can compare the CTP to CBCT perfusion. We can also compare MR perfusion to CBCT perfusion. But as I said, the thing is, this will be worthless without taking into account the clinical decision making. So we will do this whole package. The patients will be just dichotomized, CT, MR, as in France we mostly use MR, but we try to use CTP also. Yeah, it's a huge effort for us, and especially for the French neurologist to accept CTP. And after that, if we success in these steps, we will be able to try to randomize patients into 2 perfusion workflows, one with MR perfusion or CTP, like the conventional arm, and the other one with direct angio. And for that, we need the Serca solution because it will be really fast and simple acquisition, no post-processing. So at least the maximum of neurons saved. Thank you, and I will welcome your questions.
Thank you very much for a very nice overview and some exciting new prospects. Questions from the audience?
Yes, thank you for your talk. So many things to unpack. I hate to be the devil's advocate. We are doing one-stop in stroke or direct angio in our hospital. And you have presented the data, of course, that the patients will be getting better if you go direct to angio because you're faster. There's a pretty unfair study in comparison to the CT from Barcelona, where they took the patients directly into the angio, did the native head scan, nothing to see there, catheter in. Okay, of course, they were faster, a lot faster. And we cannot compete with this study with traditional imaging. So the way we do it at our hospital, we have agreed with neurologists on bringing the patients with NIHs of 10 and race, I don't know what. I'm not a neurologist, I don't remember. We bring them in, and in the beginning, we tried to like copy paste the workflow that we had from the CT. So we have a comparison, like you propose. And at one point, one of our new fellows had a so-called very sudden attack of common sense. And she said, "Why are you doing a perfusion?" And we're like, "Yeah, we copy paste from CT." "Yeah, okay, but Gregory, you will bring here a patient with an IHS of 10 with high probability of a large vessel occlusion. In what scenario wouldn't you treat this patient based on a CT perfusion?" So this is one of the questions I would like to ask you, because you're presenting some cases with M1 occlusion and IHS 18. What would you have to see in the perfusion that you would bring you to not treat this patient, especially if we have agreed on treating the patients, maybe not on your institution, I'm not sure, but commonly after the last year's trials, that we are going to treat the patients with aspects of 5 or 3 even?
Thanks for your question. I quite agree with you because this is an important question. Honestly, I am absolutely against doing only CBCT in the angio suite and treating the patients. We used to do that in the study that is negative that I told you. We got plenty of surprises, bad surprises. So honestly, if you try to do that, you try to go in a way you will have surprises. Like finally you believe it's M1 occlusion and it's not, it's a basilar occlusion. Oh fuck. Yeah, you lost 1 hour. So where's the benefit? Absolutely no. Also, you cannot be able to decide properly. Alors, for that thing, you have to take the French neurologist point of view. They are used to have MR imaging and at best MR plus perfusion imaging, meaning they are very, very comfortable. So you cannot shift completely to just CBCT scan, you know, from MR perfusion to CBCT scan. They will be completely shocked and they will just block and do not give you the patient. So we cannot do that, honestly. This is a nonsense. So at least providing just a substitute for perfusion, trying to see whether the patient, so with the arterial phase, we can see the clot, we can see roughly the occlusion. We can also see the extent of the infarct. At least we are doing less worse. Okay, so maybe for me acceptable to save time, but it's a little bit safer to do like this than just to do a CBCT and go for it without with taking all the risks. So I really agree with what you said.
So the thing is, in your presentation, you have omitted a few things that concern the cone beam CT at all in the angiosuite, meaning we do not have, to the best of my knowledge, a published randomized control study saying it's as good as a normal CT. There's one running right now, Spinners, and they're almost done with the inclusion of the patients in Europe after like 7 or 8 to go. And I'm pretty sure it will be favorable when it comes to large vessel occlusion, or at least to satisfy your neurologist to exclude a hemorrhage. I think it's good enough for that. Then the next thing is the CTA. I'm not doing any commercial here for Siemens. I just have Econo, so that's why I can talk about it. We do a CTA on the table, you know, not only CBCT, and we turn the detector into the portrait mode, so we have at least a chance to go, maybe not to see the bifurcation, the arch, maybe in small people. I don't know how it is done with Philips, to be honest, so there's also work probably to be done there, because there was a lot of work to convince Siemens like to do it in the portrait mode. And the next thing is, where do you make the cut? Do you want to transfer all of the patients, even with NIHS 1 or 2, into the cone beam CT? Because then I wouldn't feel comfortable to say to the neurologist, there's nothing there. There's no distal occlusion or a lacunar infarct that you don't have to treat with your lysis.
Yeah, thanks. So the first thing, of course, we don't expect to treat all the patients like that. Probably we have to select, like we can take the down and diffuse free parameters to select the patients, which seems acceptable for everyone. So at least highly patients highly probable to receive thrombectomy. This is the first thing, otherwise there's probably no sense to come into the angio suite. And the other thing is, yes, I have to make choices for the presentation, and I skip some data, of course. There's also interesting data with Siemens from the Toronto team. They've done several studies. Notably, there's one study where they prospectively showed that you can acquire quite good CBCT, quite good CTA, and perfusion, but the perfusion, they don't talk so much about that actually. So to be honest, we don't know, but at least you can have quite good CBCT if you improve the parameters and be able to see the occlusion, which is at least the basics. And there's plenty of data showing that. There's no randomized study comparing, and probably there's no intention to do so, or at least as you said, one study, because we already know that this will be worse, honestly. So we have to be honest. The thing is not to do the same, at least to be non-inferior, but I'm not sure the quality can be equivalent. So the thing is just to take the same clinical decision with less quality data.
Thank you very much. In the interest of time, because there is a coffee break coming now, we can take a very short question and then we will break for, yeah.
Okay, very short. What is the radiation dose if you compare standard perfusion CT, and I think most centers worldwide work with a time interval of 1 second, as compared to a full schedule cone beam Siemens perfusion with, say, 10 or 12 cycles?
So actually, there's one study where they showed the doses, and the doses are equivalent, 45 millisieverts for both. So with the Siemens protocol 10 acquisition, it's exactly the same dose, but there's a difference. With the CBCT, you got whole brain coverage.
Thank you so much for sharing your. I think we have. Can you? Is it okay to do it in coffee break? Okay. Okay.
So I just wanted to help to answer this question if there is still room for CT perfusion in stroke, because tomorrow I have another talk and they asked me exactly this. And I would say there's still room for it because we want to rule out post-ictal changes, for example, because we often have like a patient with an hemiparesis who is really a high NHSS score. And then I really would want to know, is this a post-ictal change or is this a vessel occlusion? Then we have like distal trials. We have seen that the distal trials, like 3 are neutral, that they didn't show that there is an advantage or a disadvantage. And we really have to rule out the patients who need a treatment versus the ones who are okay if we don't treat them. And I want to know from the CT perfusion, how big is the territory? Really, how big is the territory and is the central region affected? Then I would treat the patient. If the central region is not affected, maybe I don't treat. And sometimes it's really hard to see in the CTA where is the occlusion of the vessel. So for the not experienced ones, it will help us a lot to see the occlusion and how big is the territory. So I would say there's still room for CT perfusion and stroke.
Yeah. Thank you very much. And I want to say personally, the reason why I'm so excited about this is that I think we're looking into a future where we can use the study you're doing and the work you're doing to understand, are we also recanalizing or reperfusing the microcirculation when we remove the clot? And for that, I see this as the tool we need in order to give adjuvant treatment while you're in there. Thank you so much, and we look forward to hearing the results next year. And now you will be given 20 minutes to drink coffee outside and discuss this further. Thank you.